This is going to be the cardiac paramedic review questions. First one, which of the following conditions causes permanent damage to the aortic and mitral valves? Two of these things actually have to do with endocrine disorders. Conn syndrome. Conn syndrome is a endocrine disorder that has to do with the adrenal glands. Addison's crisis, also adrenal gland, right? Adrenal insufficiency. Rheumatic fever can cause permanent damage to the heart, including damaged heart valves, and will actually cause heart failure. Treatment can ease pain, reduce damage of inflammation, and even prevent rheumatic fever from occurring. So this type of infection or fever will cause heart damage. So that answer, D, rheumatic fever. Number two, which of the following statements is correct concerning cardiac biomarkers? Now, the term cardiac biomarkers doesn't get brought up a lot in paramedic, but what's interesting is when you look at anatomy, the anatomy chapter in the latest paramedic book, chapter 8, Nancy Caroline, they do talk about biomarkers. And the biomarkers, you got to understand there's three of them. One of them that is extremely popular that people talk about is troponin. Now, what these biomarkers are used for is when they draw labs at the hospital, they can look at these cardiac biomarkers and they can say definitively that this person is having a heart attack or an MI. So there's three, like I said, troponin, myoglobin is a protein in muscle, and the last one is creatine kinase. So those are the three different biomarkers. The answer is cardiac biomarkers tests can determine if an acute myocardial infarction, B, Bravo, is the answer for that one. Number five, which of the following characteristics are associated with digoxin? Select three answers or answer options that are correct. So let's talk about why we would use dig. Dig is used for, it's used to basically lower rate, typically. It's known to treat heart failure and AFib. So it tries to like relax the heart. Now, a lot of these patients that are on dig, believe it or not, if they like have a dig overdose, it's very odd that dig will actually speed up the heart rate. And some of these patients can have like AFib that goes haywire. Looking at the answers, believe it or not, the correct answers is A, increases myocardial contractility. So it strengthens that heart. Remember, we said that this is for patients that have heart failure. So weak hearts, people that are on dig, their hearts need to be strengthened. Okay. The next one is C. Patients that have dig is indicated for congestive heart failure. We just said we can use it for heart failure. The last one is F. Adverse effects will include dysrhythmias. So like I said, patients that can potentially take too much, they throw super fast heart rates. So typically, like me as a provider, if I ever am treating dig, I'm usually treating it because the person's either A, having an adverse reaction to their dig, or they've taken too much of it. The treatment for dig toxicity, we cardiovert at low dose. We cardiovert low dose cardioversion. And when I say that, it's very odd. They will start, depending on your protocols, even as low as like 5 to 10 joules, and they work their way up on dig toxicity patients. Does dig increase or decrease heart rate? What it's supposed to do is it's supposed to maintain a heart that's failing. So keep it in the normal range of not only contractility and how strong it squeezes, but it's also supposed to maintain a rate, in which is like a normal rate. We say 60 to 100. You know, I don't know why with overdose, their rates skyrocket. All I know is, yes, we cardiovert patients that have dig toxicity. And believe it or not, calcium chloride any calcium is contraindicated on patients that take dig. EKG monitor shows this rhythm. Which of the following statements is correct concerning this rhythm? On number 8, understand all PVCs means is that there is an irritable site. There's something wrong within the ventricles that's causing these things, especially they're ectopic, right? They're coming from different locations. So you could have a heart that is, I don't want to say weak, but irritable. A is the correct answer. We just have two sites in the ventricles that are irritable and firing off. Remember, if it is unifocal, they will always look the same. And what's funny is about D is it says the ectopic foci, which is the right terminology to say, hey man, it's occurring in different locations, but then it says they're unifocal, which that would not happen if they are ectopic foci. Number 10, which of the following describes a degenerative condition of the electrical conduction system of the heart that is characterized by bradydysrhythmias and tachydysrhythmias? So all 6 sinus syndrome means is, yeah, there's a plethora of dysrhythmias out there. And if they are related to the sinus atrial node, then yes, those are sick sinus syndromes. Number 12, which of the following are infectious diseases of the heart? Select 3 answers that are correct. Endocarditis, inner layer of the heart, has inflammation. Pericarditis, the outside portion of the heart, has inflammation. And myocarditis, the heart's muscle, has inflammation. Whenever you think infection, always think inflammation. First 12 lead, 72-year-old is complaining of chest pain and difficulty breathing. EKG shows this rhythm. 100% inferior wall stem. Do we have reciprocal change? Do we see depression in 1 in AVL?
Yep.
Absolutely do, right? We got positive reciprocal change. We know that this is a inferior wall STEMI. Remember, with inferior wall STEMIs, these hearts are right-sided dependent. Be careful on giving vasodilators because you will lower that preload. And remember, if you lower preload on somebody who has a right side of their heart that's already dying or damaged, you can cause some serious decrease in hypotension. Number 19, which of the following EKG leads are associated with an inferior wall? We just said it, 2, 3, and AVF. Number 20, which of the following vessels receive deoxygenated blood from the veins of the myocardium and empties into the right atrium? The second I'm reading this question, I'm like, oh, dude, well, we all know the superior and inferior vena cava, they dump into that right atrium. Which of the following vessels from veins of the myocardium? So these are veins on the myocardium. They're not veins. These are not large veins that are coming from systemic circulation. This is actually called a coronary sinus, literal blood flow that is coming from the heart itself into the right atrium. So yes, it says coronary sinus is a collection of veins joined together to form large vessels that collect blood from the heart muscle itself. It delivers deoxygenated blood to the right atrium, as do the superior and inferior vena cava. Number 21, which of the following drugs produce inotropic effects on the myocardium? Inotropic. It's a beta blocker. And what do beta blockers do? They block contractility. So remember, beta agonists, something that is a beta agonist is going to increase rate and increase strength. If I have a beta blocker, it's going to stop that from happening. Now we look at some of these other answers. We got ketorolac, which is a NSAID, non-steroidal anti-inflammatory drug. That wouldn't be it, right? Hydralazine is an antihistamine. Okay, antihistamine definitely wouldn't do that. The answer, first off, calcium. Always remember this. Calcium as an electrolyte is used in your heart, because remember, you got calcium, you got potassium, and you got sodium. Calcium as the electrolyte increases contractility. So somebody who has low calcium can have a problem and throw dysrhythmias or have heart failure. So calcium is really important. So calcium is one. The others are dopamine, which is for obvious reasons, and then DIG. So yes, you are right on those. Calcium, dopamine, and DIG were our 3 drugs that will have a inotropic effect. Remember, inotropic just means contractility, strength, and contractions. Number 23 states aspirin is contraindicated in which of the following patients? It is Bravo, which is wild, right? To look at Bravo and be like, wait, what? This kid's having an MI. We're not going to give him aspirin. Believe it or not, the FDC states aspirin is not indicated for anyone under the age of 19. That's from the FDC, which is crazy that, that aspirin at such a wild age that we can't give aspirin to anybody who's young. But that's the whole purpose behind it, is the age. EKG monitor shows this rhythm. All right. So if we were talking about typically pericarditis, right? Any of these, when we start having inflammation of tissues, we would have it in all leads. Yeah. Now, seeing that this is in other leads, now the only thing that really doesn't show me that, hey, this is potential is that's not all concave, right? So that's the first thing I would look at. Now, I do have some concave here in 2. AVF and 3 are kind of like, I would even call this convex. I do have a little bit of concave here and V6. And look at these. These are all V6Rs, V5R, V4R. So this, whoever did this 12 lead they're saying that they move those over to the right side. So this is showing that we have right side involvement on this heart. But the fact that it's all convex, the majority of all these elevations are convex versus concave, makes it this is a STEMI. I recently had a patient that had ST segment elevation in several leads, and the shape of ST segment elevation is what gave it away. Well, also the patient wasn't complaining of anything heart related. No, I don't have any chest pain. Like, what? No, the guy didn't look like he was having a heart attack or anything. But then I printed out his EKG, and I was there for a fall. So the guy fell down. I was like, dude, man, you don't see a cardiologist. And for those of you who are kind of confused on my discussion on convex versus concave, all I'm looking at is for this ST segment, if I see a concave shape that looks more like a half pipe, or a smiley face, that is usually indicative of early repolarization. It could also be pericarditis. But typically with those, whenever I see these concave shapes, I'll see it throughout the entire EKG. Okay? So just be mindful of that. If I start seeing what's known as convex, which means that J point makes an immediate turn, it doesn't like U, it does like an immediate turn. So my Q or QR S J point, and then it just creates a different route. This is called a convex appearance versus concave. So again, this one's a little bit concave, but not so much. So that's why I would say we're looking at a STEMI here. The answer is A. Number 37, which of the following are antidysrhythmic drugs? Antidysrhythmics, DEF. A lot of people, they don't talk about procainamide much, and I don't blame them. But at the same time, is procainamide making a comeback? Fortunately, it is. Sorry to tell y'all. One more drug that might get thrown into the mix of talking about American Heart Association. DIG would not be considered an antidysrhythmic. DIG, let me see what they're classifying that as. Oh, it is pronounced as an antiarrhythmic and blood pressure support. Does get used to treat some dysrhythmias such as AFib. Methylprednisone is solumedrol. Atropine is an anticholinergic. DIG would be a decent answer. These three are definitely the most common that get discussed and paramedics. So number 45, EKG shows this rhythm. That ain't good. D. How do we know that it's not sinus? Makes it idioventricular. Number 46, which of the following are characteristics associated with PVCs? So first one, okay, echo for sure, right? Echo says are considered ectopic, right? We talked about this earlier because they originate other sites other than the SA node. Absolutely right. E is 100% right. The other one, believe it or not, bravo. Ventricular ischemia can cause PVCs to occur. This is why they say when somebody is having PVCs, we can administer or consider giving oxygen and fluids to these patients. There is no actual medication that you would be giving for PVCs. And for some folks, PVCs is completely normal. Okay. PVCs just are not normal when they're given or when they come out too frequently. We see too many PVCs. Not normal. We're looking at a pathologic Q wave. Now, basically what a pathologic Q wave is it's wider and deeper, longer than normal. When we say something's typically pathological, it's greater than one little box in width. So it's usually greater than one little box in width for it to be considered pathological. And then the depth should be less. It's supposed to be less than a quarter of the height of our QRS complex. But if it's greater than a quarter, like this one looks like it's about half the height of our QRS complex, that's considered a pathologic Q wave. Now, if you don't remember what a pathologic Q wave is, all it's telling you is that this patient's either A, having an MI, or this patient has had an MI in the past. Number 49, on an EKG, which of the following represents the polarized state of cardiac action potential? It is. So let's talk about it. When we talk about depolarization, polarization, or repolarization, a lot of terminology getting thrown around. Whenever I say that something is depolarizing, I'm saying that action potential is occurring and it's creating a contraction. Whenever I say something is repolarizing, it's getting ready to contract or depolarize again. And whenever we say the term depolarization, typically we're talking about either A, the SA node causing a P wave, or B, a QRS complex. We all know repolarization occurs in the T wave, and that's just how we notify it. Now, talking about polarization, because we use the term depolarize and repolarize, but I didn't say anything about just straight up polarization. Polarization just means it's waiting to be depolarized. And where on an EKG is it going to be waiting? Isoelectric line. How'd you remember it?
The way I remember all those three is that for depolarization, it's like discharging the electricity across the tissue. Repolarization, it's recharging. And then polarized, it's ready to go.
Yeah, that's a good way to look at it.
That works for me.
When it's polarized, it's just saying that it's ready to go. It's on the isoelectric line, and then you're going to see a depolarization or a repolarization occur. Number 51. Uh-oh, we see something over here. This girl's got a zipper, and she's got a pacer. Oh, I just gave it away. 70-year-old surgical. Yeah, artificial pacemaker. That's what we're looking at. Number 56. Which of the following describes congenital heart defect? I want to say tetralogy of Fallot was in my national registry exam. Tetralogy of Fallot's a weird one because it is 4 different diseases of the heart that are congenital defects. So first off, pulmonary valve stenosis. So the pulmonary valve doesn't open and close like it should. A ventricular septal defect. There is a shifting of the main aorta it shifts in a different location. And then there's also thickening of the right ventricle, known as ventricular hypertrophy. All 4 of these things are found within tetralogy of Fallot, which is a congenital heart defect. Number 61, which of the following would likely cause the heart rate of an adult to fall 20 beats per minute during an intubation attempt?
Vagal stimulation.
Exactly right. So if I go ahead and stick my laryngoscope blade in somebody's mouth, I stimulate a gag reflex. This is going to cause a vagal response, and then we can have a drop in the heart rate. Jumping into the next one, which of the following statements is correct concerning this rhythm? Drives me nuts. They're showing us another. We're looking at another statement. Number 74, which of the following drugs produce a chronotropic effect on the myocardium? This is an interesting one. First off, what the hell is verapamil? Okay, so verapamil and diltiazem are the same, right? So they're not actually both diltiazem, but they are both calcium channel blockers. B, we know, is a sympathomimetic that will increase rate. And C, albuterol is also a sympathomimetic that will increase heart rate. We know albuterol as the bronchodilator. Yes, it does bronchodilate, but it does also have a sympathetic reaction when used. B and C. Number 76, which of the following conditions activates the renin-angiotensin-aldosterone system? Holy, that is a big system. To increase blood pressure and maintain cardiac output. 100% hypoperfusion. So let's talk a little bit about this system first off, because we can say that, hey man, like it does deal with the renal system, right? So that could possibly throw you off. But whenever we talk about the renin-angiotensin-aldosterone system, this system kicks on when you're hypotensive and your body says, holy shit, we need to bring up pressure. It's associated with blood pressure regulation. It modulates or fixes blood volume, sodium reabsorption, potassium secretion, and water reabsorption. All right. So it starts moving around fluids throughout your body to try to fix your blood pressure problems. So this does occur with hypoperfusion. Number 81, which of the following characteristics are associated with left ventricular failure? Select 3 answers. Left ventricular failure, B, C, and D. Okay. Left ventricular failure. Left ventricular failure can cause dysrhythmias. Okay, tachycardias, pulmonary edema, everyone knew that, right? We got left-sided heart failure, that blood is starting to back up. It's causing my patient to have crackles or rales. And then PND, right? Proximal nocturnal dyspnea, that's orthopnea. My patient, whenever they lay down in bed, they get short of breath because of their positioning. People, they wake up, night sweats, they have to sit up in a recliner, and that's how they'll typically sleep because of PND. This is 100% left ventricular failure. EKG shows this rhythm. What do we see in this EKG? See a PAC, right? So everyone sees that right here is where this PAC is occurring. We see that we know it's a PAC because not only does it have a P wave, but it's also narrow and complex. What can cause PACs? Stress. Listen to this, man. Most people will experience PACs at some point in their lives. They are often a result of stress, caffeine, or even alcohol. Number 94, 24-year-old bull rider is in cardiac arrest. I didn't like this question. During the event, he lands on the ground and the bull steps directly in the center of his chest. Arena personnel immediately find this patient apneic and pulseless. Based on the patient's condition, what's your diagnosis? It is B, commotio cordis. Now, could this patient have an aortic dissection? Of course they can. Could this patient have a tamponade? Of course they can. Bad, right? Commotio cordis, we're having an R wave on a T, right? 97, we're almost here at the end. Which of the following are locations where congenital heart malformations most likely occur? This is challenging, man. I'll tell you why. Malformations always, or I can't say always, but they mainly deal with septums and valves. Because when we think about malformation of, let's say, tetralogy of Fallot. Remember I said there was a problem with the septum, ventricular septal malformation. Very common. Well, the septum have an issue where there's a hole in it and blood will leak from one side of the heart to the other. Knowing this, we can kind of cross some stuff off. Aortic arch, no. Internodal pathway, no. So that leaves us with 4 answers. Ventricular septal wall, atrial septal wall, and then we got 2 valves. It actually is BCE. Pulmonary valve is more likely to have a malformation than the mitral valve. The last question, EKG shows us rhythm. In this rhythm, P waves that occur without subsequent QRS complexes are suggesting what? B, the electrical impulse was not conducted to the ventricles. That's all it's saying. Now, if I take a look at this and I say, hey man, look at the distance between this P wave and this QRS complex, and I say, hey, is it any different than this one here? If I'm able to say that they are all the same, then it is 100% not going to be, for one, a second degree type 1 or a third degree block. We can all agree that there is something wrong with conducting the ventricles. There are missed QRS complexes, which all that means is it's a conduction of the ventricles. That is bravo as well. That concludes this, man.